Hey everyone, and welcome to this explainer. Today, we're diving straight into the microscopic roots and the macro ripple effects of diabetes. We're going to break down exactly what happens when the body's energy regulation system misfires, and we'll look at it from the molecular level all the way up to the systemic consequences. If you want to understand the true pathogenesis of this condition, well, you're in the right place. Let's get started.
Okay, so here's our roadmap for today. We're going to cover understanding glucose and insulin, contrasting type 1 and type 2, seeing the impact on major organs, diagnosing the disease, and finally looking at treatment and management.
Section 1. Understanding glucose and insulin. Let's start by understanding the basic fuel system of the human body.
Right off the bat, let's clear up a really common mix-up. The condition we're exploring today is officially called diabetes mellitus. It's a metabolic disease characterized by chronically high blood glucose levels. Now, you might have heard of another condition called diabetes insipidus, and aside from both causing increased thirst and frequent urination, these two are actually completely distinct conditions. Diabetes insipidus is quite rare and has to do with kidney water regulation, not blood sugar. So today, our entire focus is on the metabolic powerhouse, diabetes mellitus.
To really grasp this, we just need to follow the journey of a single glucose molecule. It brilliantly illustrates how our system is actually supposed to work. Glucose is the ultimate fuel source for human cells, right? But it can't just casually walk into a cell. It needs a way inside. That's where the pancreas comes in. The pancreas contains these incredible, specialized clusters of cells called the islets of Langerhans. Within these islets are beta cells, and they secrete a hormone called insulin whenever your blood sugar spikes. Think of insulin as the essential key. When insulin binds to receptors on our muscle and fat tissue, it basically unlocks the cells. It allows glucose transporters like GLUT4 to move to the surface and physically pull the glucose inside. When this lock and key mechanism works, your blood sugar stays perfectly balanced.
Section 2, type 1 versus type 2. So now that we know how the system should work, let's look at how the pathogenesis of diabetes completely disrupts it.
Generally, there are three main classifications of diabetes mellitus: type 1, type 2, and gestational diabetes, which happens during pregnancy. But to really understand the core pathogenesis and the long-term metabolic dysfunction, we are going to sharply focus our lens on just type 1 and type 2 today.
The absolute most crucial thing here is understanding the fundamental difference in how these two diseases break that lock and key mechanism. Picture type 1 diabetes as a total autoimmune factory shutdown. For reasons researchers are honestly still untangling, the body's own immune system sends T cells to attack and destroy the beta cells within those pancreatic islets of Langerhans. The results? Absolute insulin deficiency. The factory is destroyed. No keys are getting made. Now, type 2 diabetes, which makes up a massive 90 to 95% of all cases, is more like a busted lock. It kicks off with insulin resistance, which is often driven by genetics combined with environmental factors like poor diet and physical inactivity. The pancreas is making the insulin keys just fine, but the body's tissues, the locks, actively resist them. The pancreas tries to overcompensate by pumping out even more insulin, which leads to hyperinsulinemia. But eventually, the massive strain causes progressive beta cell failure.
Once this metabolic system breaks, a cascade of systemic chaos ensues. Because glucose can't get into the cells, it just backs up in the bloodstream, creating severe hyperglycemia. But the cells themselves are still starving for energy. So what does the body do? It panics. It triggers enhanced lipolysis, rapidly breaking down your fat for fuel, which the liver then converts into ketones. Especially in type 1, this can lead to a highly dangerous acidic state called diabetic ketoacidosis, or DKA. Meanwhile, the kidneys are going into absolute overdrive trying to flush out all that excess glucose, pulling massive amounts of water with it. That's exactly why extreme thirst and polyuria are classic, glaring early warning signs.
Section 3, impact on major organs. Once the blood becomes chronically saturated with glucose, we start to see a massive ripple effect on the macro level.
Because diabetes is a systemic disease, having all that excess glucose floating around in the blood is essentially toxic over a long period. It heavily damages both the microvascular and macrovascular networks throughout the entire body. We're talking about severe cardiovascular complications like ischemic heart disease. We also see diabetic kidney disease. To put the sheer severity of this into perspective, in type 1 diabetes, having end-stage kidney disease increases the risk of premature mortality by an astonishing 18-fold. 18! And of course, it profoundly affects the liver, leading to metabolic dysfunction-associated steatotic liver disease.
Now, here's a critical, real-world takeaway for why this matters so much in everyday healthcare. When a person with diabetes suffers a myocardial infarction, a heart attack, they are significantly more likely to present with atypical symptoms. In fact, the classic chest pain might just be mild or literally entirely absent. Why? Because chronic high blood sugar actually damages the autonomic nervous system. This nerve damage means the body's internal alarm bells just don't ring the way they're supposed to. A silent heart attack is incredibly dangerous because it leads to fatal delays in diagnosis and treatment. It brilliantly illustrates why a very high index of clinical suspicion is absolutely vital for any clinician treating diabetic patients.
Furthermore, we see this vicious, bidirectional loop happening with the liver. In type 2 diabetes, insulin resistance means insulin can't properly suppress lipolysis anymore. This leads to a flood of free fatty acids entering the liver, driving up fat deposition or steatosis. But it's a two-way street. That fatty liver, in turn, starts secreting excess inflammatory cytokines, which actively worsens the body's insulin resistance and drives hyperglycemia even higher. It's literally a metabolic feedback loop that just accelerates the disease.
Section 4. Diagnosing the disease. Let's shift gears and look at how clinicians actually catch these glitches in our metabolic software. This perfectly breaks down the absolute gold standard of diabetes tracking, the hemoglobin A1C test. Unlike a quick finger prick that just gives you a snapshot of your blood sugar at one exact moment, the HbA1c test measures how much glucose is physically attached to your red blood cells. And since red blood cells live for about 3 months, this test gives us a highly reliable 2 to 3 month historical average of a patient's glycemic control. Keeping that score between 4 and 6 is considered excellent, while creeping up past 9 represents poor control, putting the patient at a really high risk for all that systemic organ damage we just discussed.
Aside from A1C, clinicians have a pretty robust toolkit to pinpoint exactly what's happening. A fasting plasma glucose test of greater than 126 milligrams per deciliter, taken after an 8-hour fast, is a clear indicator of diabetes. They might also use an oral glucose tolerance test, where a patient literally drinks a sugary liquid and their blood is tracked over time to see how efficiently their insulin clears that glucose out. But what if a doctor needs to know for sure if you have type 1 or type 2? That's where the autoantibodies test is a game changer. By testing the blood for specific immune markers, like anti-glutamic acid decarboxylase autoantibodies, clinicians can confirm if the immune system is actively destroying those islets of Langerhans, thereby solidly confirming type 1.
Section 5. Treatment and management. Now that we've diagnosed the problem, let's look at the pharmacology and the interventions used to fight back.
We really have to ask ourselves, facing a disease that rewires everything from the pancreas all the way to the kidneys, how do we actually outsmart it? Okay, let's dive into this final crucial piece. Because the core issue is either a lack of insulin or a deep resistance to it, the treatment absolutely has to be tailored to the specific pathogenesis. For type 1, because the beta cells in the islets of Langerhans have been wiped out, the absolute cornerstone of survival is exogenic insulin substitution therapy. We literally have to manually provide the keys the body can't manufacture anymore. However, a major, really exciting focus of advanced treatment right now is islet of Langerhans transplantation. This is where healthy islet cells from a donor are infused into the patient's liver to essentially restore natural insulin production. For type 2, the goal is to lower that resistance and support the struggling beta cells. This relies heavily on lifestyle modifications. We're talking rigorous nutritional therapy and physical activity to naturally improve insulin sensitivity. Pharmacologically, agents like metformin are used alongside other glucose-lowering injectables to help the body process glucose way more efficiently. And for both types, because of that massive systemic ripple effect, management requires continuous aggressive evaluation for cardiovascular disease, arrhythmias like atrial fibrillation, and kidney dysfunction.
I want to leave you with this thought to ponder. Right now, our treatments are largely reactive, right? We inject insulin, we take medications to force better sensitivity, we manage the cardiovascular fallout. But as we understand more deeply how the pathogenesis actually destroys the beta cells within the islets of Langerhans, how close are we to finding a way to permanently regenerate them? Could future technologies repair the lock and the key entirely, rather than just treating the symptoms of a broken door? It is a fascinating frontier in medical science. Thank you so much for joining me for this explainer. I really hope exploring the mechanics of this complex disease has given you a much deeper understanding of both the molecular roots and the macro consequences of diabetes. Keep learning and stay curious.